If you do have a question or a comment, the most effective way to let us know that is using that chat box. So if you're new to doing one of our webinars, that's really how we communicate with one another. Your questions and comments are only going to be seen by myself and either Tara or Shelly, and we will respond to those. If you do have a specific question or comment maybe related to a particular case or your particular family that I can't necessarily address during the training because we are kind of on a time schedule and I have to be mindful of that to make sure that we get through all the information, I'm going to give you guys my contact information. Feel free to keep this, to jot this down. This is the most effective way to reach me. If you have any technical issues with regards to the webinar, go ahead and type those in and either Tara or Shelly will get back to you on that so that I can just keep moving forward with the information because we do have a lot to cover in a pretty short period of time. So fantastic. Looks like everybody can hear me okay. So we have conquered that piece of technology for this morning. All right. So if you were with us last week or if you're just joining us, I want to just kind of give you an overview again of the competencies for this particular training. The Adopt Care training, again, this is kind of the level 1 training that we offer through the Adoption Exchange. It's really a foundational training. It's normally a 6-hour in-class training, but what we're trying to do is to really make this training available to more folks who might be outside of the Front Range, who maybe geographically can't come to a face-to-face training, or if there's logistical issues, with childcare and things like that. We always try to be mindful of those pieces. So what we're trying to do is to move some of the trainings into this type of a format where we can record it and we can put it online so that when folks want to access it, you can do it at your leisure. You can do it at home. You can play it and stop it and pause it and come back to it in a modality that's going to be able to meet your needs more effectively. So we are recording, and hopefully shortly in the near future we'll have this training up online through the Adoption Exchange as well as the Adopt Care Advanced training. And before we end the call today, Tara or Shelly is going to talk to you for a minute about the upcoming Adopt Care Advanced training that we're doing also through webinar. And it'll be coming up in the next couple months, so she wants to make sure that you guys know about that if you want to go ahead and kind of put that on your calendars to register when the registration opens up. So for this particular training, last week we covered a couple of these competencies, but really this is just kind of the outline of the entire training. We looked at values and assumptions as it relates to kind of the entire world of adoption. We briefly kind of looked at the characteristics of the children's histories, their trauma histories, and a little bit on effective adoptive parenting. And I do want to mention last week that I know that some of the handouts that you guys were given did not correspond. Some of the handouts that you got last week were actually from the Adopt Care Advanced curriculum. But you should have received in an email. If you haven't checked it, check your email. You should have received the correct handouts from session 1, and it should be handouts number 1 through 5. So make sure that you have those to refer back to. This session today we're going to cover 3, 4, and 5. So we're going to look at child development and adoption, some of the emotional conflicts for the adopted child, and briefly touch on some psychosocial issues, common diagnoses, and start to kind of address some of the treatment strategies and interventions working with an adopted child as well as the adoptive family, the whole family system. And then next week we will finish out with 6 and 7. We'll get a little bit more into specific types of interventions and treatment, as well as some strategies to address challenges related to adoptive families. and then have hopefully a pretty good discussion about post-placement support and services and where we're at, not just here in the state of Colorado. I know we might have people from other states on the call, but where are we collectively as a system, and what are some of the barriers, and what are some of the gaps, and what are some steps that we can kind of take in our own communities to try to adjust some of those barriers and gaps. So that hopefully gives you just a little bit of an outline of kind of what to expect. Again, if you guys have not done a format like this before, there are going to be points in the next couple hours where I'm going to ask a question, and it's really helpful if I can have your feedback, and the way that I get your feedback is in that chat box. So I'm looking forward to kind of hearing some of your thoughts and comments on some of the topics that we're going to hit this morning. So all right, let's get started. We are going to do the case scenario that we didn't get to last week, and really what we were looking at is some of the challenges when we are assessing families who want to be an adoptive resource for children. So really kind of what we're assessing on their end versus what are some of the issues and needs that the children have, and really kind of looking at that dichotomy, how sometimes it can be very different. So there's two case scenarios, and what I'm going to do, because I know maybe some of you have not been able to print these out or haven't been able to see them yet, is I'm actually going to read them. So please bear with me. But I think this is also going to kind of help kind of hammer the point home that there is a really big difference in the perspectives when we kind of bring our children and our families together and what that might look like. So you guys can see this on your screen, but this is Jimmy, and Jimmy is 5. So Jimmy has been in 4 foster homes since he was placed due to law enforcement discovering a meth lab in his home 6 months ago. Since this was the second time his parents had been found with a meth lab, both his mother and stepfather were convicted of producing and selling an illegal substance and are currently serving 5 to 10 years in prison. The only relative the county could find was his grandmother, who said that she had taken care of the children before and it was, quote, too much for her. Jimmy's sister, her name is Jennifer, she's 2. Jimmy and his sister are quite a stark contrast. Jimmy is biracial, his father was African American, and Jennifer is blonde and blue-eyed. Jimmy is and was the parentified child and always made sure his sister was fed and taken care of. This was a problem for the first foster mother because Jimmy continued to try to be the parent for his sister, and this caused a conflict in the home. The caseworker decided that for both children to thrive, they had to be separated for a while. So Jimmy was placed in the second foster home where the parents were not able to deal with his behavior, which included tantrums, striking out, and wandering the halls at night. This placement disrupted, and he was sent to a third home with much the same result. Jimmy and Jennifer were placed together in a legal risk home because the new caseworker decided the siblings should be together. Jimmy continued to throw tantrums, but they did reduce in number. However, he was very guarded with the mother in the home, where his sister seemed to attach right away. After 3 months, the mother called the caseworker and said she had to get Jimmy out. When asked about his behavior, she said, "He's creepy like a little Chucky." The adoptive father did not feel this way, but admitted that he was bonding to Jimmy and his wife was not. The decision was to keep Jennifer in the home, so not to disrupt her again, and Jimmy was moved to a legal risk adoptive home with the Simmons family by himself. So normally if we were in a classroom type setting, what I would have done is divided, individuals. Some of you would have read Jimmy and some of you would read the Simmons, and then we would kind of have a discussion based on which perspective you were coming from. So for the sake of discussion, so what I'd like to hear from you guys is, what do you think, or what do you believe Jimmy is thinking and feeling when he shows up at this new prospective adoptive home with the Simmons family, what do you think some of his thoughts are? What do you think he's expecting based on that little tidbit of information that you got about him? What's Jimmy's perspective of this placement? And again, not really having much of a say on what's going to happen to him at this point. So I'm hearing that he obviously would be confused, very much so. That Jimmy's thinking that this placement isn't going to last. I bet he's also thinking, what could I do to kind of move this along so that they can move me to another home? Maybe I can get back with my sister. Let's see. How long he'll be at this home before he's moved to another one. No one cares about me, so why bother trusting anybody? Absolutely. Confused and scared. Doesn't believe, and I wouldn't believe that this placement would last. Feel lost. How long am I going to be here? Why can't I be with my sister? Why can't I be placed with my sister? And who are these people that she's with? And are they taking care of her the way that she needs to be taken care of? Absolutely. That level of anxiety that some of our kids carry around, especially those that were in sibling groups and had that role of taking care of their siblings and not knowing if they are split up, where they are, who they're with. Are they being taken care of the way that they like to be taken care of? That level of uncertainty and fear and anxiety, I can't imagine what that's like for some of our children, guys. And then we expect them to go to school and sit still and pay attention. And I don't think any of us could really do a good job of that. How long will I be here? If I misbehave, if I, kind of up the ante a little bit, can I move this along? Feeling out of place, confused, have no idea what the outcome is going to be. So think about also how little control our children have when they're in the system. Our children and our youth, how little control they have and who's really making most of the decisions for their life. Just think about that for a minute. Worried that he'll not see his sister again. Perfect. All right. So let's look at a different perspective. Let's look at the perspective of the family. So let me move this along for you. All right. So here's the Simmons family. Renee and John Simmons are white middle-class folks in their 30s. They've been married for 10 years, have not been able to have children just due to infertility issues. They have a large extended family. Each of them came from a group of 4 siblings, and all the grandparents are still alive. There are also numerous nieces and nephews. Each sibling has several children. The family all live in a metro area and get together for holidays, birthdays, and vacations. Renee and John have taken care of their nephews and nieces and are much loved for their generosity and good humor. Their inability to have children has put a damper on their otherwise happy life. They finally decided to make a family through adoption. They saw the pictures of Jimmy, who is 5, and Jennifer, who's 2, on a website and fell in love with them right away. The children appeared so happy and were so handsome and would fit right in age-wise with some of their cousins. So they called the county and began the adoption process. They agreed to be legal risk parents because the county assured them there were no relatives who would take the children, and because the county said the children's current adoptive home was disrupting because the mother was not able to bond with Jimmy. This was very strange to Renee, as she and her husband loved all children. The Simmons were disappointed that the caseworkers decided to leave Jennifer in her current adoptive home. However, they were so excited about the possibility of the children coming to them that they agreed to take just Jimmy and to keep in touch with Jennifer's adoptive family so the children could see each other sometimes. Okay, so sit with that perspective for a second, and then share with me what are your thoughts about what you believe Renee and John are thinking and feeling when Jimmy shows up on their doorstep. with his caseworker for the first time, what that scene might look like, what kind of thoughts are going through their head. And how is that very different from the perspective that Jimmy is coming to their doorstep with? Big expectations for a perfect family. Well said. Absolutely. Again, they haven't had any children. They're super excited. You know, they have this big extended family. What I hope isn't happening is that they have all of their 55 extended family members all hiding behind the front door with balloons, and when Jimmy walks through the front door, they're going to jump out and say, like, surprise, we're so glad you're here, and he's going to freak out, and then that they believe that this is going to be the best way to welcome him into their home. Wondering if the Simmons have any clue or idea about Jimmy's journey and the anxiety that he carries with him. Very good point. How much preparation have they had? You know, how much are they aware? And sometimes it's not much. You know, you think about our families that when they're new and they've been waiting for a placement and they're super excited, and you know, I have to kind of respect where they're at and where they're coming from, but then also thinking about from Jimmy's perspective, you know, very different from where this couple's at. They're excited, believing in the very best. You know, it's a celebration day for them, but it's a day that represents a lot of terror and loss for Jimmy. Absolutely, well said. Probably think he's very excited, might not be thinking about how he's experiencing the significant loss of his sister. Jimmy's 5 and has had way more trauma than his sister. You know, somebody's commenting that sometimes parents think that, you know, older children have more understanding and will be grateful. I'm not quite sure what these kids should really be grateful for, but I absolutely appreciate your point. Yeah, the child feels cheated and removed from his sister. So really the point of kind of the exercise, again, guys, and I think you absolutely get it, is to kind of think about the two perspectives. When we put these two entities together, you know, our families are coming in with one viewpoint and a belief system, and our children who have experienced this trauma and these multiple moves and separations and ongoing grief and loss are coming into it from a very different perspective. And we have to respect and honor both of those pieces. And we really collectively, whatever our role is as professionals and support folks, need to really recognize that, and we need to have some conversations about it. You know, we need to kind of validate the differences, but yet the individual's perspectives, and coming into this agreement and this arrangement and this situation. So again, I hope that it just kind of brings to light a little bit how we need to be sensitive on both ends, because our folks are coming and our children are coming with very different experiences that are going to impact how this is going to work, and or maybe in some cases how it doesn't work. So I appreciate your help with that. Nice job. All right, so we are going to jump ahead. So competency 3 is looking at child development and adoption. There's just a little bit on this. Again, this training we really just kind of cover really just kind of the tip of the iceberg on some of these topics, and then we really kind of dig deeper in the Adopt Care Advanced training. So for competency 3, you know, really going to kind of look at how adoption is a lifelong process. We're going to look at a handout that identifies the tasks for each developmental stage of life, as well as an additional adoption-related task for each of those developmental stages. And I really like that handout. It's been really helpful in working with folks over the years. And then to really just kind of highlight the impact of trauma on a child's development. And we really go more into this again, and I hate saying it but it's kind of a preview for the advanced training as we really kind of dig into how trauma, abuse, and neglect affect the developing brain and how that manifests in individuals, and then how that comes out through behaviors. So again, this is going to kind of be the foundational component of it. And then just kind of the reminder, past issues are triggered at each developmental stage. This is a human being statement. So for all of us, we all have our own stories, our own trauma backgrounds. At each developmental stage, previous traumas or previous grief and loss issues resurface. It's normal. It's expected. So it doesn't always look the same as we get older and as we kind of move through some of these more advanced developmental stages. But past issues come up. And how I like to relate this to adoptive families is that if my husband and I, we've been married for 10 years and maybe we had some, marital issues, a few years ago, but we went and we got help and we kind of worked through that. And then we decide that we want to be, maybe a foster adopt family, and we bring in some children into our home. I should expect that because I'm changing the whole family system, the whole family dynamics, including my marriage and my relationship to my partner, that some of those previous issues that we had are going to come up again. And that might not come up to the point where it's going to severely impact our ability to, be a functioning married couple, but it's going to come up and it's going to, present itself. And I think, again, part of our job as professionals supporting families and adoptive families and adoptive couples is to normalize that process, that it's going to happen. So just kind of prepare yourself and think about what do you need to do to kind of be proactive. So again, just something to kind of think of. So there's a couple of handouts, and they are embedded here in this, the PowerPoint that we're just going to kind of look at. So handout number 6 is looking at adopted children's evolving understanding about adoption. And so just so you guys know, again, if I didn't say it this session, any of the handouts that are on here, feel free to print. You can use, you can share. We just ask that you keep the adoption exchange citation at the bottom of the handouts, but you can, if you're in a role of a therapist or the caseworker, or if you're doing home studies, or you think that some of these handouts might be helpful for some of the families that you're working with, feel free to share. We want to just make sure that the information gets out to everybody who can use it. So this one is kind of broken down into 3 age groups. It looks at preschoolers, middle childhood, and adolescence. This, again, our children's evolving understanding about adoption. What does adoption mean? If any of you are involved with doing life books with children and adolescents, this is a piece that I would want to pay attention to, especially if we're talking about an adoptive placement, that how they understand and how they question adoption changes. Obviously, our brains are growing and developing, our thought processing, our higher cognitive abilities are evolving as we chronologically get older. So this just is kind of a helpful thing, that for preschoolers, that it's important that they understand that they were first born to birth parents who, for whatever reason and however you feel it's appropriate to explain it, just couldn't take care of them. In middle childhood, you can see there's an increasing understanding, with regards to reproduction and being able to differentiate between being born and being adopted. A little bit older chronologically, comparing themselves to others, and can understand blood relations. What I do want to say about this handout is that it uses a lot of chronological ages. And so I feel like I have to share for all of us that we know that children who have experienced trauma and abuse and neglect oftentimes are behind in different developmental stages. So chronologically, they may be 7, but when you break down the different developmental domains, when you look at social functioning, when you look at cognitive functioning, when you look at educational functioning, when you look at emotional functioning, a lot of our children are not at the same point as their chronological age. So when you see handouts like this, I just want to caution you to be more mindful of where your child is at or where the child you're working with is at, not getting fixated on their chronological age. We have to meet their needs appropriately. So for some of these children, even though it says by age 7 or 8, they start comparing themselves to others, for some of our children it might not be until they're a little bit older. And that's just where they're at. You know, adolescence is my favorite group. It is probably one of the hardest groups. But when you think about just typical adolescent development, so think about just the typical pieces. You guys all remember back to that period of time that you don't want to think about ever again because it was really hard and it was so confusing. You know, we really are just trying to figure out who we are as an individual, how we fit into the world, wanting to find a collective group to belong to. Our peer group became way more important than our family system, whatever that looked like. We engaged in more high-risk, very risky behavior. We didn't really have a fear of any permanent consequences or anything really bad happening to us. Our brains are not fully developed, and that's a neurobiological fact. There are parts of our brain that are not fully functioned or not fully developed, and so part of the reason why we do engage in some of that behavior. But think about just the normal, typical child development or adolescent developmental stages, and then throw adoption on top of it. And then throw grief and loss on top of it, and then throw multiple placements, and then throw separation, and then throw, I mean, talk about trust and attachment and connection in the context of relationships, and how difficult that can be. So again, this is just kind of a guide for you. I want to spend a little bit more time on the next handout, which gets into, it's 2 pages, but what I like about it is that it focuses on Erikson's psychosocial tasks of development. So you can see, you know, again, looking from infancy, toddlerhood, preschool, middle childhood, adolescence, young adult, middle adulthood, and late adulthood. So the typical, you know, Erikson psychosocial tasks, if you took your child development class in school, you probably covered this, you know, in infancy, trust versus mistrust. Toddlerhood and preschool, it's that autonomy versus shame and doubt. Middle childhood, industry versus inferiority. Adolescence, ego identity versus identity confusion, and so on. What I like about this handout, and you know, when I have parents who are looking for some resources or some information on, you know, how can I be sensitive about the adoption as it relates to my child's, you know, developmental stages, I pull this one out. And what I say to them is that for each of these stages, where we pulled this information from, which David Brzezinski's book, Being Adopted, The Lifelong Search for Self, which is an amazing book. That's a great resource if you guys are not familiar with it. But what they've identified are specific adoption-related tasks that fall under each of those developmental periods. So, you know, for example, let's look at, you know, infants, the trust versus mistrust. When that attachment cycle is really in its prime, you know, children, babies have lots of needs. They let us know that they have needs by crying. You know, typically a regulated, responsive adult or caregiver goes in and meets those needs every single time. by that caregiver going in and being regulated and being, calm and interacting with that baby in a healthy, appropriate way, that baby's brain is learning, through watching and through experience how to calm their own emotions, how to begin their own regulation. And then the baby and the caregiver engage in that, kind of falling in love experience all over again. There's lots of oxytocin that's flowing through the brain. The baby calms down because they have a regulated caregiver who's also calm. And then for those of you that have ever had infants, sometimes it doesn't take very long, and then our babies have a need again, and then they let us know. And then we repeat that cycle, sometimes hundreds of times a day. But what we're teaching our infants in that process is that when you have a need, I'm going to meet that need every single time, and I'm going to meet that need in a loving, healthy, regulated way. So that's how our babies learn at a very early age to calm their own arousal system. But the bigger piece with that whole arousal relaxation cycle or the attachment cycle, whatever you want to call it, is that when it happens like that, how I just described it, every single time, there's a blueprint that's being imprinted in the baby's brain. And the blueprint is actually pretty powerful. And it really sets the stage for how this baby sees life, love, family, and relationships in the future. It sets the template or the foundation for how this baby feels about themselves. Am I lovable, worthy? Adults are safe. I can trust them. The world is a good place. That template, that worldview, it's what Dr. Rick Delaney calls a working model. When our caregivers are responsive and regulated and meet the needs of our babies on a consistent basis, our children develop a positive working model, a positive template or viewpoint of how to see life, love, family, and relationships, and they carry that with them through the rest of their life. When we have a situation with a baby where the baby still has needs, right? Babies need to be held. Babies need attention. Babies need to be changed, need to be fed, right? They need stimulation. So they have the same needs, and they let us know they have the same needs by doing the same thing, by crying typically. And if you're a highly attuned parent, you have picked out that there is a different cry for a different need for your baby. That's a highly attuned parent. But when you have a parent who's struggling with maybe untreated mental health issues, or you have a parent who is addicted to drugs and alcohol, you have a parent who is in a domestic violent relationship and it's all they can do to take care of themselves and get out of bed every day, you have a parent who is clinically depressed, you have a parent who basically is just not available, or you have a parent for whatever reason harms their child every single time they cry. That is not going to be a responsive caregiver. That is a caregiver who is not regulated. And so depending on what the interaction or the response is, being hurt, being yelled at, being shaken, being ignored, sometimes responding, sometimes not responding, that is creating a very different template or blueprint in that baby's brain. So that baby is learning a lot of different things about life, love, family, and relationships. That baby is developing a message about themselves or a negative working model that I'm not lovable, I'm not worthy, the world is not safe, I can't trust anybody, I have to take care of myself, adults are not okay. So a very sophisticated process that happens with very young children very early on, which is why those first couple years of interactions with a primary caregiver is so critical to what type of a working model, what type of a template are these children going to come into our foster homes, our kinship homes, our adoptive homes with. Because if we have a little bit of that understanding, I think that's really helpful for our resource families to know. And sometimes I know it's very difficult as a caseworker or even as an intake worker to get the answers to some of those questions about what did happen. But I think just kind of having that information and just kind of assuming and educating our resource families that, if our kids did not get their needs met on a consistent basis, and we know that our children experience whatever types of trauma, abuse, and neglect, that we can kind of infer that this is what their template, this is what their working model kind of looks like, and this is how they're operating, and this is why they have a really hard time trusting. Any of us guys, if we were in those kids' shoes that had the inconsistent response, or every time we had a need we got hurt, we would be doing the same thing too. We wouldn't be forthcoming. We want to connect with humans, and we want to connect. Human beings are designed to be in relationships with one another. So this is where I just kind of go back to, why it's a challenge, especially for children who have disrupted attachments, is that if our children have been hurt or traumatized in the context of a relationship, and this is what my mentor Julie Alvarado taught me many, many, many years ago, and it just the more that I think about it, the more that I use it, the more that it is so right on. If our children and our adolescents have been traumatized in the context of a relationship, which I think all of you would agree with that statement, that children who've come into foster care for whatever reason through the foster adopt system have been hurt or traumatized in the context of a relationship, they are only going to heal. Their trauma will only heal in the context of a relationship. And I understand how difficult it can be for kids who've had early disrupted attachments, the work that goes into that. But what we're tasking our parents to do is to almost rewire their brains. So to slowly unravel the neuronal connections that adults are not safe, they're not trustworthy, they just hurt me, so I'm going to take care of myself, into rewiring those neurons to adults can be trusted, they are consistent, they can be predictable, and they can take care of me. Well, that doesn't happen overnight. That doesn't happen in months sometimes. Sometimes that doesn't happen for years. That is a process that has to happen, and how that process happens is based on every interaction between our children and our parents, and parents, whoever those are, foster, kinship, adoptive parents, whoever it is. Every interaction has to be focused on the relationship in order to really heal the trauma. So I hope that kind of makes sense a little bit. And I know I kind of went down a rabbit hole for a minute, but I think it's really important to kind of have that understanding. So kind of going back to this handout, you guys can see, again, each of the typical Erickson psychosocial tasks. So let's look at adolescence for a minute. So the psychosocial task of adolescence, ego identity versus identity confusion. Again, the primary focus of adolescence is who am I and how do I fit into this world? Where do I belong? Who do I belong with? How do I define myself? And it's where that peer group really takes precedence over our family system, whatever that is. But if you add on top of basic adolescent developmental stuff, what are some of the adoption-related tasks that might also be going on for our adolescents? Further exploration of the meaning and implications of being adopted, wanting more information. So if you are in a position where you do life books, or you're a clinician who does life books with children and adolescents, and maybe you've been working on this for a couple years, you may notice when they hit this stage that they want more details. They want more information as it relates to their story and their identity. as being an adopted individual. Being able to connect adoption to one's sense of who am I and how do I fit into this world. Racial identity issues. If you have folks who, in transracial adoptions who are from a different, background and ethnicity of their adoptive family, really kind of digging deeper into that. And what does that mean? And maybe wanting to find more connections, with a culture or an ethnicity that they maybe haven't had much exposure to before. Looking at physical differences from family members in more detail. Adoption-related loss, especially related to the sense of self. So that theme of loss and grief and loss you'll see really comes up in each of these developmental stages. And as I said last week, you really can't have an adoption without there being loss. And grief really goes hand in hand. So you guys have this. I hope this will be helpful for you in some, some context depending on, what your role is. So we're going to go ahead and we're going to move ahead. Again, if you guys have, any other questions about any of the information that, I can't touch on when we're on the call, feel free to contact me after and we can talk in more detail. Okay, so the impact of abuse and neglect on a child's development. So children may have missed key developmental tasks and have cognitive, emotional, or social delays. That's why when I mentioned a few minutes ago, I think it's really important that we have to kind of put the chronological age aside for a lot of our children. If you have like a typical child development chart, those are really helpful. A typical, if my child is 3 to 4, what should I be seeing? How much should they be talking? What should a typical 3 and 4-year-old look like? Those are helpful to giving us a foundation. That's helpful to kind of give us, this is where typical children for this chronological age fall in the 50th percentile. That's really helpful for us to be able to look at where my kid is actually falling in these different categories. It's safe to assume that a lot of our children who have experienced and a lot of our adolescents who've experienced trauma are going to be behind in maybe 1 or 2 areas. And the only way to really kind of figure that out is a couple different ways. If I'm now the primary caregiver, I'm going to be very observant and I'm going to pay attention to how my child interacts with their world and their overall daily functioning. I'm going to use a typical child development chart to kind of help give me maybe a baseline of kind of where to jump off of. I may be reaching out to some of my local partnering agencies like a local child developmental center or an agency that maybe does other developmental assessments if I suspect that maybe my child might have been exposed to drugs and alcohol in utero. There are a couple of really good clinics here in Denver that do a very comprehensive multidisciplinary child assessment, but also can look at, based on records and testing and things like that, can look at potential substance abuse exposure in utero. So having those assessments and those documents can also help us kind of figure out where our children and adolescents might be a little bit behind and where we need to meet them at. Because that's the bottom line as a parent. And sometimes I think some of the frustrations that a lot of our parents have is, I know parents don't like being frustrated all the time, and if we had some more information that could help them meet the needs of their children effectively, it might help the system overall. And I think, my just 2 cents is that where we're really struggling collectively as a system and we're just trying all these different interventions and we're trying this mode of therapy or we're trying this medication or we're trying this and we're trying that is, I just wonder how helpful it would be if we could get, brain imaging scans for our children and adolescents who have experienced abuse, neglect, and trauma to be able to look at their brains and to be able to see where some of the deficits are occurring, to see what parts of their brain have been impacted by trauma or maybe have been impacted by, alcohol exposure in utero. To be able to tell us how to parent effectively. I can't give my kids, 6 steps and expect them to remember all of them. Maybe being able to look at their brain and say, well, that particular medication isn't going to really fix that part of the brain, so I need to do other, daily interventions to try to help my children, function appropriately every single day. I wonder how helpful that would be for a lot of folks to have the right tools to be able to parent their children based on where their kids are at, rather than us just kind of guessing at a lot of stuff, or maybe just putting Band-Aids on things that aren't really working. So until I can get Medicaid on board with that, I know it's just kind of food for thought out there, but with all of the research and what we know about the brain at this point, I really think our system kind of has to step up a little bit and think about, even from a financial standpoint, how much money we could be saving if we could give folks really concrete information on how to effectively parent and meet the needs of your kids. So anyway, I won't talk about that anymore. Okay, so something to think about too, that strategies and habits learned by children to survive in a chaotic home environment are now described as maladaptive in other settings. So let me break that down for you very simply. Think about children and adolescents who come from abuse and neglectful environments, who come from very chaotic, very inconsistent environments. They create and they learn strategies and behaviors that keep them alive. So our children learn, if I don't have enough food, I need to go find food. I need to go sometimes take food, sometimes I need to go steal food, sometimes I need to go dumpster diving to get food. If I don't have food, I need food, basic human need. So our children learn very appropriate coping mechanisms and strategies and behaviors to help keep them alive in their chaotic, inconsistent environment. When we then place them with our foster kinship and adoptive families who are not chaotic, who are not inconsistent, who do have plenty of food, who do meet the needs of our children, do you really think that all of those behaviors and coping strategies that they used in their previous environment are just going to go away? And most of you know they're not going to go away. They bring those survival skills into their new placement and they continue to do it because that's all they know. That is their norm. And I hope that makes sense. We don't just shed that part of who we are because now I'm in a new placement and after 24 hours they have lots of food and they give me everything I want and I'm not going to be struggling. Our kids and our teens don't know that, guys. But we continue to expect that they're just going to let go of those behaviors within like the first 24, 48 hours, a week, 2 months, 3 months, 6 months of a placement. Those coping mechanisms have now been hardwired into who those children are. It has kept them alive. It is very appropriate. It's just not appropriate in the current setting, but it served a purpose for them. It's very unreasonable for us to just expect that these kids let go of that. Just, you don't need that. You don't need to do that. Why are my kids hoarding food still? It's been 3 months. It's been 6 months. I don't get it. I don't understand it. Well, take a deep breath and let's go through it and let's break it down. because there's a function and a purpose to every behavior. So that behavior of hoarding food, there is a function and a purpose to it. And until you can step back, step out of your own lens that you see the world, because your lens that you see the world is not the same lens that our children see the world and life and love and family and relationships. Until you can take off your lens and try to see it from the lens of the child based on their experience and their story, you're going to constantly be at odds with that child. There's a function and a purpose to every single one of those behaviors. And for some of these behaviors, guys, it takes a long time to slowly start to replace that previous behavior with something that is more appropriate in the current setting. And if we know that the brain only learns through repetition, lots and lots and lots of repetition, think about how long it might take for some of these behaviors to kind of loosen their grip for some of our children and our adolescents. And depending on the length of time that our children practiced and had to use that particular type of behavior is also going to have an impact on how long it's going to take for that behavior to not be as powerful and for it to be replaced by something that is more appropriate. I hope that makes sense. The next bullet point on the slide is really disturbing. And I actually had to do some research on this. This was based out of a study that was done in Texas, and it was actually from 1998. So, we'll honor the date for what it is. But what it's stating is that 3 out of 4 school-age children who have spent any time in foster care have a history of being sexually victimized. So, and I think this really speaks to the fact that when a lot of children come into foster care in this country, this isn't just here in Colorado, this is in this country, that they often come in for something related to neglect is usually first, and then maybe physical abuse. Maybe it's related to domestic violence. Maybe it's related to parents who have substance abuse issues. And I say we collectively as a system often do not know that children have been sexually victimized until after they've come into the system. When they've been placed in a home where they start feeling a little bit safe or a little bit comfortable or start establishing a relationship with the caregiver, that they start disclosing information. Oops, sorry, I didn't mean to move that slide ahead. So again, what this study, and this was in Texas, let me also say that, again, back in 1998, that 3 out of 4 children, school-age children, who had spent any time in foster care had been sexually abused. That doesn't mean that they were sexually abused in foster care. It just means that somewhere in their history, somewhere in their story, they had been sexually victimized. So it's a really high number. And I think it's a really valid point to share with especially foster parents maybe who are new coming into the system. I know that I talk about this when I do the foster parent core training for the Colorado State Foster Parent Association, is that there are folks who have a really valid fear about bringing kids into their home who maybe have been sexually victimized, especially if they have maybe other children in their home. And that there is I think, kind of a myth out there that if a child has been sexually victimized, that there is some correlation, some direct correlation, that they become sexual perpetrators. And there's nowhere in the research that supports that claim. The bottom line is, with children who have been sexually victimized, their view, their worldview of what normal sexual behavior is has just been changed. It has completely been skewed. So think about their lens from the perspective of a child who's been sexually victimized. They now are under the belief, incorrect, but under the belief that this is normal behavior. So when we collectively as a system learn that a child has been sexually victimized, it's our job, with the work of our parents who have these children 24 hours a day, to all have the same understanding that it's now our job to help reteach this child that that's not normal sexual behavior. What happened to them was not normal and it was not okay. And so using a team of people to help that child kind of tweak their lens so that they learn more appropriate sexual behavior. That's really what our jobs are. So again, there's a little piece of information on the bottom of the slide too. Ongoing effects from abuse and neglect and drug exposure require special kinds of parenting and continuing long-term parental patience. With patience, I think, has to come education and understanding. We have to give the information, we have to pass this information on to our parents. So I hope that there are those of you on the phone who are parents and those of you that are professionals, because the more that we both are hearing the same information and can share the same information, I think better off collectively that we're going to be. So again, that this is a unique type of parenting. This isn't like how you parented your biological children. So I always say very graciously to folks who come through, new foster parents who come in who have raised their own biological children, congratulations. That is an amazing feat. But you're pretty much going to have to throw out everything that you did with your biological children, and you're going to have to take on a whole new parenting perspective. And this also isn't about fixing children. This is also going to challenge you. You are going to have to change maybe some of the ways that you used to do things. You are going to have to really sit and think about how you thought about certain things. That you are going to be challenged as an individual. This isn't about putting a kid in your cookie cutter mold. This is about how can our caregivers effectively meet the needs of our children based on where the children are at. And if you are so rigid in your own belief and your own practice, and yes, you're a good person, you raised your biological children, but this is not the same. This is very, very different. So really finding parents who have that understanding, who are flexible, who understand commitment and the depths of commitment is really, really key. So for those of you that do home studies, gosh, love you. How we really kind of figure out some of that stuff. But, again, some really key components for an individual and their capacity to be really effective. If we want our parents to be trauma-informed, all of us like to talk about, being trauma-informed. If you really want our parents to be, trauma-informed, first and foremost, we have to give them accurate information. We have to share what we know. But we have to really be willing to work on ourselves too, because we bring our own baggage into the work that we do, whether it's a parent or a professional, like I talked about last session. Okay, so we're going to move on to some emotional conflicts as it relates to adoption. So the first thing we're going to do is talk about 7 core issues in adoption. I alluded to this a little bit last week. Identify the impacts of loss and multiple placements. And then we'll look at how to apply some of these concepts and strategies to minimize the impacts of abuse and neglect. Okay, so this is going to be handout number 8, and it's going to follow this slide. I talked a little bit about last week. This is going to be a review probably for some of you. The 7 core issues in adoption, otherwise known as the lifelong issues of adoption. Most of you, I'm sure, are familiar with it. So this, again, really just kind of an overview. If you are not as familiar with this topic, I would encourage you to go online and Google it. There are lots of good books and articles that go into a lot more depth with regards to these issues. So when these 7 core issues were identified, it focused on as it relates to the adoptee, a birth parent, and the adoptive parent. So what we used to call the triad, and some people still do kind of call it the triad. When I, many years ago, started teaching this training, I felt that there was another group that was missing from the initial research, and were also affected deeply by all of these 7 areas, and that group is siblings. So in some of the information that's out there, some other groups have also included how are siblings affected or impacted by the 7 core issues in adoption. And siblings can be biological siblings. It could be, other foster siblings, just siblings in general. How is that group also impacted by these lifelong issues? So, grief and loss, we've talked about, rejection, guilt and shame, identity, control, and intimacy issues. What I want to say first off about these 7 core issues, when the 2 researchers initially looked at identifying each of these areas, a lot of it was based on, for adoptive parents, we're looking at folks who struggled with infertility issues, and it was related to a lot of like infant domestic adoptions, not necessarily from the foster care perspective, like designated, planned, infant adoptions. So you'll see in some of the descriptions under adoptive parent, a lot of it relates back to infertility issues. So what collectively our adoption world has done is to kind of open these core issues up as it relates to foster care, kinship, adoption, but all types of adoption, foster adopt, kinship adoption, even international adoptions as well. So let's go through. I know that probably the handout is sideways for you guys. Sorry about that. But just to kind of go over and kind of think about it. And again, add siblings. So go through here, and how are siblings affected when it comes to loss? A lot of them, it's pretty self-explanatory. You can't have an adoption without grief and loss. How is rejection woven into the 4 groups? For the adoptee, rejection as it relates to self-esteem. You can only be chosen if you were first rejected by your birth parent. Rejection as it relates to the birth parent. They might reject themselves as irresponsible, unworthy, because they're allowing the adoption to occur. Maybe for birth parents, they come to expect and just kind of create rejection in their life. Under the adoptive parent, as it relates to rejection, they may feel ostracized because of infertility issues, maybe expect rejection. Guilt and shame, a lot of that's pretty self-explanatory. It's hard to kind of figure out, the best way to kind of go through these topics. We actually had a class that I did for a little while for the Adoption Exchange, and it was on the lifelong issues of adoption, and really spends a lot of time just kind of going through each of these, but then adding, more current kind of input from the perspective of, adoptive parents and foster parents and kinship parents on how are you impacted by each of these 7 areas. From a clinical standpoint, I think it's really important that we explore each of these areas with our clients and whatever their role is. If they are the child or the youth, if they are the birth parent, if they are the prospective adoptive parent, having these conversations, bringing this stuff to the forefront. With our kinship families, I think the biggest area that I think we're more aware of now, but that we still need to dedicate some time to, is if I'm a grandparent and I was really looking forward to being a grandparent and having that grandparent role, and something happens and I get that phone call where I'm being asked if I can take my grandchildren, and if I'm in my late 60s, early 70s, and my grandchildren are 6 and 8, and now I have almost overnight assumed the role of parent, I kind of don't have the ability to be that grandparent anymore. That role of parent has now superseded the role of grandparent, and I was really looking forward to being a grandparent. That's a loss. That's a loss of who I am or who I wanted to be. So talk about grief and loss as it relates to changes in role identification. That's a pretty heavy loss for our grandparents, and they're the #1 group of caregivers as far as kinship providers go in this country. In the United States, I think last time I checked, we had close to 7 million grandparents raising grandchildren in the United States, not able to be grandparents anymore. That's a huge loss, and we don't really often do a good job of talking about it and exploring that with them and what that's like, and providing a safe place for some of just those role and identity changes. So, the other one that's really big on here is identity, kind of across the board. So when you look at these handouts, what I would encourage you to do at some point, and maybe not today, and I don't want you to do it on your weekend or anything like that, but is also think about siblings and how our siblings are also impacted by these same areas. And then really just being very cognizant in the work that we're doing that these 7 issues are interwoven into the lives of all 4 parties. Now I kind of call it a quad instead of a triad because I include the siblings in that. Those 4 groups are all impacted by these 7 issues. And they're lifelong, guys. That's the other thing. They're lifelong. These all will resurface at various developmental stages through the course of our life. So they kind of ebb and flow. The intensity of how they come up at different developmental stages varies. But these are lifelong issues, lifelong areas of implication, however you want to describe it. Okay? I hope that gives you a little bit of an overview to kind of work with and whatever your role might be. All right. So the next slide has a couple of handouts that go with it as well. But some factors influencing a child's reaction to separation and loss. And I know a lot of you on the call probably have a lot of experience with this. First and foremost, we know that every placement move traumatizes children. Now, just because we've experienced trauma doesn't mean that we have horrific outcomes later in life. But it is well documented, especially if we have children who have multiple placements. We need to do a better job of trying to minimize the effects of trauma when we do placement moves. And I know that we're all a lot more aware of that now than we used to be. So some of the other factors that influence a child's reaction to separation and loss: the age and stage of development. So again, I'm not necessarily fixed on the chronological age, but really what's the stage of development that my child is at? What's their understanding based on, their emotional functioning or their cognitive functioning? What is the child's level of attachment to caregivers? How can we assess like a child's bond or connection with birth parents and siblings? That's going to influence their reaction to separation and loss. What's the child's perception of the reason for the separation or even the reason for the move? So have you guys ever taken the time to kind of ask your kids? And I say your kids, and I'm kind of talking collectively, whatever your role might be, on what's their understanding about why they have to move, and hearing what that is. And it's heartbreaking sometimes what their understanding is, and how much, even if it was something that maybe was out of their control, it had nothing to do with them, that they feel like it's because of them, it's something with them, something in who they are, and it's because of them. That's a big burden for little children to carry around with them. How well the child is prepared for the move. I think I can safely say, and I'm not saying this to try to offend anybody, but we really need to do a better job of when we transition and when we move kids. And I know that there are a lot of circumstances, and even when I was a caseworker, I didn't do a good job of moving kids, and I'll be the first to admit it. Sometimes I didn't have the time that I wanted. Sometimes it was an emergency type situation. Sometimes, I had kids that were on the run and I just had to pick them up and put them somewhere, and I didn't really have the ability to take the time to see if this was going to be a good fit. I get all that stuff, guys. Maybe what I'm referring to is when we're going to be transitioning a child into an adoptive home, that should be a very purposeful, very intentional, planned process. And there are some guidelines that are out there on how long and what the steps should look like over the period of maybe a week or the period of a couple of weeks. Or the recommendation, last time I looked, for moving children, especially teenagers, out of residential into an adoptive home was like a month. And it was a month of very planned, gradual transitions, increasing in frequency and intensity over the period of a month. And I know that when children and adolescents know that something is coming up, something pretty big, like a court date or a move or a termination or an adoption, that we typically see an escalation and an increase in behaviors. That's really to be expected. That's not the time to pull back. That behavior, again, there's a function and a purpose to that behavior. So how can I recognize that this child is having an emotional response to what's going on? They know that something big is happening. How can I integrate that? How can I work with that so that we keep moving forward? So again, in whatever your role is, I don't have all the answers. How can we take baby steps to doing, a better job of preparing and transitioning our children? And then, is there going to be any post-separation contact with important people? So previous providers, can our kids still have contact with their, previous foster parents, or with some of the staff maybe in the, the group home or, the residential facility, if it's appropriate. If those people were important to our children, honoring those important connections is something that we really have to think about. How can we keep that? The more people in our kids' lives, really the better, as long as they're appropriate. And I get that. So there's a couple of handouts to kind of give you a little bit more information kind of on this section. So handout number 9 is talking about developmental effects of parental separation and loss. And I also use this handout quite frequently when I still work with families who really just kind of want a breakdown of, for each, kind of developmental or chronological stage, what might be some of the short-term effects and some of the long-term effects, and then how can I help minimize? What can I do to be proactive? And so that's why I really like this handout, because it goes over some of the short-term effects to pay attention to, some of the potential long-term effects, and then what can I do if my kid falls in these age ranges to try to be proactive and to minimize some of the impacts. So for little guys, some of the short-term effects of parental separation and loss is a regression in terms of dependency needs. You might have a child who becomes more clingy and cries more often. Again, there's a function and a purpose to every behavior. And it's really hard with children who are pre-verbal or whose trauma happened before they were verbal because they can't explain to us in words why they're behaving this way and why they're having this meltdown. They're never going to be able to tell us why. And we as adults often get fixated on wanting to know the why. Well, the reality is, guys, you're not always going to know the why, but you're going to know that your child is obviously dysregulated and your child obviously needs you. So meet them where they're at. Be there for them. Hold them. Stay regulated. Let them know that they're safe, that right now everything is okay. Some of the long-term effects for infants, difficulty ever meeting dependency needs of others, trust issues. They also develop, again, that negative working model about themselves and how they fit into the world. How can I be proactive in helping minimize the effects of loss with an infant? Ensuring that new caretakers are available on demand for the infant. You have to respond to these children every single time. This is different than maybe those of us that raise biological children. And maybe you're of the mindset, you don't want to respond to your kids every time they cry because then it creates a sense of, they're entitled and they're, going to expect. It's not what this is about for children who have trauma histories. You're not going to create a child who, is entitled when they already have a trauma history. You have to meet their needs every single time. Following a consistent routine. If it's possible to transfer routines from the previous family to the current family, keeping them on that same schedule or same items they liked or same food they liked. Again, that structure consistency is really important for little ones. It's important for most of us, but especially for little ones. So take a look at this. Again, I really like this handout. I think it's very helpful, especially for parents who want some tangible, give me some practical ideas. What can I do? This is what you can do, guys. So share this. It's a couple pages long, so I'm just going to flip through it. Print it off. Make sure that you have it. Here's another resource if you're interested in books. I'm a big collector of books on a variety of topics, but this one has been in my library since I think I was 20 or 21 years old when I started working in a group home with adolescent girls. It's Dr. Vera Fahlberg, and it's the citation on the bottom of this page. It's the book, A Child's Journey Through Placement. It is, I think, probably the Bible with regards to foster care. It's not a book you necessarily read cover to cover, but it is packed full of really rich insights, strategies, interventions, case scenarios. It talks about every possible topic you could think of. I would use this book, A Child's Journey Through Placement, and then also the book Foster Parenting that came out by EMK Press. It's also kind of a reference resource book. It's a collection on different topics from parents and professionals that really, again, if you're a foster parent, you should have it. They also have one called Adoptive Parenting. So there's foster parenting, kinship parenting, and adoptive parenting, and they were all put out by EMK Press. You can find them on Amazon. So depending on kind of where you fall, might be some helpful books to add to your library if you're so inclined. All right. The next handout is just a collection of some quotes from some experts in the field. There's a couple on here that I just want to highlight, as well as some websites that I want to give you. The somebody's asking what was the author for foster parenting. If you look it up, just type in foster parenting and then look it up by EMK Press. So EMK Press is a publisher that puts out in all of those books. So foster parenting, kinship parenting, and adoptive parenting. Or if you look on Amazon and type in any of those titles, the one that comes up that was published by EMK Press, that's the book that you want. So thanks for asking about that. Okay, so I'm going to look at a couple of these. I want to read. John Bowlby, otherwise known as the father of attachment, did some amazing research well before his time, but I want to read this quote to you. Multiple placements have catastrophic effects, causing overwhelming combinations of intense anxiety and loss. Every placement, including the removal from birth parents, becomes a disruption to him and to his working through his developmental stages and tasks, including regression and inability to adequately develop conscious. The other one that I want to share with you is also by Dr. Fahlberg, and it's on the bottom. So Dr. Fahlberg describes the link between abuse, stress, and anger. The same neurobiological systems are involved in the stress and fear response as are involved in anger, aggression, and violence. When a person is under stress, there is an activation of the sympathetic nervous system and a decrease in production of serotonin. Activation over a long period of time can cause the brain to organize around a high arousal level. Because of the high arousal level, minor stimulation causes major response. In addition, decreased levels of serotonin are associated with a decreased ability to modulate one's emotions. Excuse me. The other thing that's really important to know is that when we are in a heightened state of fear or stress, the other chemical that gets released in our brain is cortisol. And some of you might be familiar or have heard cortisol has been in the news quite a bit the last 10-15 years. What's also important to know is that if we are in those heightened states of fear and threat consistently, that we have an overload of cortisol that gets dumped into our brain and our body. Some of the implications of high levels of cortisol, just really quickly, and this is something that we go into much more detail in the advanced training. High levels of cortisol in your brain and your body will make you physically sick. So think about it. If you have children or work with children who complain a lot about headaches, stomach aches, feeling nauseous, sometimes you get a lot of those complaints when it's around going to school. And what I want to say about that is please do not be quick to dismiss that your child is telling you this all the time just to push your buttons and make you mad. School can be a very stressful and a very dysregulating environment. The bullying stuff is out of control. I know all kids are mean, but if you are different at all, other kids tend to hone in on that. If I am worried about my biological parents, if I'm worried about my siblings that are placed in another home, if I am worried that I'm going to get moved again, if I'm just fearful in general, I have a lot of cortisol flooding my brain and flooding my body. So I might feel nauseous and have headaches all the time. I'm not going to be able to learn a lot, to process a lot of information if I am in that heightened state of fear and threat. So high levels of cortisol will not only make you physically sick, high levels of cortisol actually kills certain brain tissue, kills cells in the front part of the brain. So the part of the brain that it attacks is the part of the brain that allows us to kind of get in connection and relationships with other human beings. So if I have had disrupted attachments early on, I didn't have a caregiver who met my needs, and I have trust issues, and I don't really connect with people because of that, and now I'm just kind of dysregulated all the time, and I have high levels of cortisol in my brain and my body, and that's going to attack the part of my brain that will allow me to detect safety in the context of relationship with another human being, I'm going to have a neurobiological difficulty even connecting to other people. And that's not a choice. Because a lot of times we like to think like our kids are choosing to do certain things. What the research is now showing us with how trauma impacts the brain and brain development and cortisol and overall brain functioning, we know now that it's often not a choice for most of our children, guys. They can't. They neurobiologically can't do certain things, which again I go back to, if we could take a look at some of our children and our adolescents' brains, and I could look at those images and I could say, wow, well now that makes sense. Now it makes sense why my child has difficulty doing A, B, or C, or has a real struggle with getting close to other people, or that makes a lot of sense, or oh my gosh, that's why the information is not, why he doesn't process when I tell him to do things verbally. So again, there's some really fascinating information that's out there. So hopefully if you'll join us for the next training, we can kind of dig deeper into a lot of this stuff. And I hope that a lot of it will really start to sink in and make sense, and that we can really kind of shift how we're practicing overall and our understanding, and helping our parents with this understanding, and that some of the stuff, honestly, they're not being willfully disobedient and defiant. They can't. So our job is to help them so that they can. So what do I need to do in working with a team of people who also get it, who are also trauma informed, that can help you figure out, where do we start? What do I need to do? Okay, all right. Okay, so the next slide is looking at the effects of trauma on the child and the adoptive family. So I've already talked about the negative versus the positive working model. So I kind of jumped ahead on that a little bit.
The conference has been muted.
Can you guys hear me?
Yeah, thanks. I had to remute. I don't know why the button has been unmuting, so thank you.
Okay, awesome. All right, well, let me keep going. Okay, so we talked about the negative versus the positive working model, that our children can become caught in a negative neurophysiological feedback loop. That's the dysregulation. So some of us say stressed out. I like to say dysregulated. When I'm calm, then I'm regulated. So when our children are constantly triggered, in a state of fear or threat, and that can be real or perceived, fear or threat, their thermostat, if you will, in their brain of how much cortisol it takes to get them back to just a place of regulation, to a place of calm, it actually changes. When you're consistently in a state of fear or threat, it takes more and more and more cortisol in your brain to try to calm you down. And then we talked about just a minute ago some of those implications of having large amounts of cortisol in your brain and your body. So when we are constantly in a state of fear or threat, it can actually change some of the hardwiring in our brain. Our children's survival behaviors, those behaviors that were functional in their previous environments, are all coming from a place of fear. And there's really two core emotions if you want to break it down very simply: love and fear. So think about how you want your responses to be to your children when something happens. Are you going to respond from a place of fear, which a lot of us get stuck, and we do because we go back to what we know, and that's okay. The hard part about being really trauma-informed and a really regulated parent is responding from a place of love, and doing that in a regulated fashion, because our children only learn how to regulate their emotions in the context of their relationship with their caregiver. So they're only learning how to calm themselves, which is why timeout is not super effective for a lot of children who have trauma histories, because our expectation is that if they go sit in the timeout chair, they're going to calm down. The reality is, guys, if our children have had disrupted attachments, did not have their needs met early on, did not have a regulated caregiver that responded to their needs, they have not learned how to regulate their own emotions. They do not have the capacity to regulate their own emotions and calm down on their own. They are dependent on their caregiver to help teach them how to do that. And the brain only learns through repetition. So we have to keep our kids near to us in the context of relationship, because our kids have been hurt in the context of relationship. So I'm a big fan of time in for children who have been traumatized, because I can't have the expectation that my kids, when they come into my home, who have disrupted attachments, who have haven't learned how to regulate their own emotions, they do not have the ability to calm themselves down. They're only going to learn how to do that in relationship to me as a regulated caregiver. So I'm still going to address the behavior, but I'm going to do it in the context of relationship. So here's an example. So some people want to know about time in. So here's how time in works. So let's just say I have a 5-year-old in my house who has a trauma history, and they, I don't know, throw something across the room, and I've already told them, please don't throw across the room. So they do it again. So instead of putting them in a chair in a different part of the house away from me, because what I also want to be careful of is sending a rejection message all over again to kids who already kind of feel rejected. So I know that my kid needs my help to make a better choice, whatever that is, and maybe they're getting a little scared about something, or they're getting a little triggered by something. So I need to help them. So I need to help them calm down. I need to help them feel safe, and I need to do that in my presence. So what I might do is maybe I'm in the kitchen, peeling carrots or something for dinner. What I'm going to do is, let's just say Johnny's 5. What I'm going to do is I'm going to have Johnny come in the kitchen with me. So again, I'm going to bring them to me. So I'm going to heal trauma in the context of relationship. So I'm going to bring them close to me, not like don't have to sit on my lap or anything like that, but be in my presence. And maybe we peel carrots together. But I'm very cognizant of my own regulation, so I stay calm so that I can help him calm down. And I'm not going to do a lot of talking, because if my kid is dysregulated, if my kid is fearful, if my kid is upset, the trap that most parents fall into is wanting to know why they did that. Tell me why. Why did you do that? I told you 5 times. Stop doing it. Tell me why you did it. And then you get the, I don't know, or you get the shoulder shrug, or you get something, and then you just get upset. What do you mean you don't know? How do you not know? I told you this 5 times. Rather than slow and low. So another thing to keep in mind is when our kids get really big, and our kids get really loud, and our kids get really scared. So think about a temper tantrum on aisle 4 in Walmart. They're laying, flailing, screaming, slobbering, not making any sense. So think about the big meltdown on aisle 4 in Walmart. Your kid is obviously dysregulated about something. I don't need to know what it is in that moment, so stop asking. It doesn't matter, and they're not listening to you anyway. Their brains are just on survival mode. Until you can help your child in that moment on aisle 4 in Walmart calm down and feel safe, you might have to sit on the floor with them. You might have to sit right next to them with people watching you and people making their own assumptions and people who don't know your children. You may have to sit with them and just let them know it's okay. I'm right here. Drop your tone. Stop saying 1,000 things a minute. just be with your child, be a regulated caregiver that they need to help calm themselves down. If you guys want some more examples about time in, email me and maybe we can talk. But I hope that just gives you a little different perspective. Our kids are going to reenact their past behaviors in a new setting. Dr. Rick Delaney has a term for this. It's called imported pathology. It's basically when our kids bring their past chaos and inconsistency and trauma in a little suitcase and they bring it into their new placement, and your home is fairly quiet and it's orderly and you have rules and you have structure, and that's not normal for a lot of our kids. So they want to kind of stir the pot a little bit, if you will. So they like to recreate the chaos and the inconsistency in their new homes because that's all they know. So again, understand what the behavior is about and then go forward and address it from there. So trauma can create barriers to attachment formation. I think that's pretty self-explanatory. Sometimes when we have kids who have, pretty significant attachment issues, they might be really good with one parent and really difficult with another parent. And typically with children who have attachment issues, their behaviors are directed towards the female. The female represents the mother figure, the one who didn't take care of them the way that they were supposed to. And if the female happens to be the parent who is home, more than, say, if you have, a partner who works outside of the home, that usually a lot of those behaviors get directed towards the female, the mother figure. And our moms are not crazy. So as professionals, we need to understand attachment, and we need to normalize it, and we need to help. If it's a two-parent household, we need to help the other parent support the one who is having to deal with the brunt of the behaviors, that are being directed towards them. And sometimes, we have children who have experienced such trauma that, their behaviors end up sabotaging a placement. But I think, again, if we can really try to step back, and I'm not saying these behaviors are all easy, guys. I'm not Pollyanna. I don't live in, la la land. I know I've had kids in my home that I've done respite for where I never thought that I would have to deal with some of these behaviors. And I do, and I have. But I have to, in the moment, be able to kind of step back and try to figure out what it's about. And sometimes I don't know what it's about. And I just have to do the best I can, and I have to seek out support, and I have to ask for ideas and suggestions and, try to exhaust every avenue that I can, but really stay focused on how can I promote healing trauma in the context of a relationship, because that's the only way that trauma is going to heal for our children, is in the context of relationship. And that's why it's so hard for some of our kids, and why some of our kids do really well in residential settings, because they don't really have to attach. It's not a family setting. It's not hitting the core of all of that stuff that happened for our kids when they were little. They can keep it superficial. They can kind of keep you at hand's distance. When we put kids in family settings where there's been disrupted attachments, it's bringing up all of that early stuff that happened to them and that they never got. And that's very, very, very painful for a lot of kids. All right. Handout number 11 is an article. I want to point this out. This is by Dee Paddock. She's an adoptive parent as well as a therapist. It's a really good article, a couple pages long, that looks at going and growing through grief and loss, parenting traumatized adopted children. She quotes Dr. Bruce Perry in here, who is another individual. If you're not familiar with Dr. Perry, P-E-R-R-Y, his website is childtrauma.org. He also has 4 free classes that you can do online at childtraumaacademy.com. He's got a couple of really good books out there that I also like. The first one is The Boy Who Was Raised as a Dog, and the second book was called Born for Love. If you're looking for some other types of resources, those are really, really helpful. So when you have time, I think sorry, trying to type at the same time. This is a really, really helpful kind of a summary of some of the things that we already talked about, but really kind of going into, you know, when kids are in that fight, flight, and freeze mode, that trauma mode, kind of what can you do, how trauma triggers grief. There's some really good practical strategies in here. So take some time. If you find it helpful, again, share it with others that you might be working with. It's a really honest article, and I really appreciate it. It actually comes out of the North American Council on Adoptable Children, which is NACAC. They actually have a really good conference coming up in Tennessee, I believe in August, if you're looking for a conference to go to. So I'm just trying to be mindful of the time too. So I'm going to flip through. It's a 4-page article. So I'm going to flip through here. You guys have it. Okay, so the next part we want to kind of get into is, again, this is going to be just an overview. Let me see how many. All right, so we've got a couple different areas we've got to go through. So I'm going to skip this one so that we can kind of start getting into some of the information. This article, handout number 12, is a summary of attachment. So I've already talked about it when I went through kind of that cycle of attachment. Again, I want to point this out so that you know that it's in here. It talks about, you know, kind of the diagnosis of attachment disorder. Attachment falls on a continuum. Mostly, I would say the majority of our kids who come into foster care have some sort of attachment disruption. Doesn't mean that they meet the DSM or the Diagnostic Statistical Manual diagnosis for you know, attachment. It's a disruption. If you've been separated from your biological parents and they didn't effectively meet your needs, you might have some attachment issues. Doesn't mean that you meet the criteria for a full-blown diagnosis. So just the attachment, you know, falls on a continuum. This article also goes into some of the things, some of the signs and symptoms that you might see for a child who has some attachment difficulties. And then a little bit of a breakdown on kind of attachment therapy. If you are in a position as a parent where you are participating in therapy, or you know, a therapist tells you that they do attachment therapy, I just like to encourage you to ask them kind of what does that mean exactly, to kind of explain it to you so that you understand what they're doing and what they're working on in therapy, just so that you have that awareness and that understanding. The next article is by Dr. Perry, and so the website is at the top of the article if you want to browse around and get more familiar with his work. His group is out of Texas. They're out of Houston. His group is the one that gets called in when there's a, you know, a really large, usually, event that happens involving, you know, children, some sort of traumatic event. His group got called out to Waco after the whole Branch Davidian, David Koresh type of thing happened, where there were a lot of children that were raised in that cult-like environment that were left after most of the their parents were killed kind of in that shootout. He's been called out to do evaluations and assessments on that large group of children. I think they were in Utah, that were in social services custody for a period of time. So he's really one of the pioneers when it comes to a lot of the neuroscience as it relates to trauma and how it impacts the brain. He does have 4 free classes that you can take, which is an amazing resource if you want to do more. Again, this is kind of going over the brain and brain development. Really, really helpful article. He's got tons of other articles on his website that you can also print off and that you can use. So please use that as a resource. I can't recommend it highly enough. And all right, so I need you guys' feedback for a second. So these are some common diagnoses for adopted children. Also on handout 14, which is the next page, there are some other diagnoses. But what are you guys, if you're working with them or you have the kids in your home, what are some of the other mental health diagnoses that your children and adolescents have that are coming into your home? Reactive attachment disorder, autism, depression, anxiety, failure to thrive. Good. So here, on this list, adjustment disorder, absolutely. So again, attachment issues, ADHD, ADD. Some of our older kids have the oppositional defiant disorder, affective or mood disorders, including bipolar, depression, post-traumatic stress disorder. Okay, good. All right. Some of the, if you're not kind of in the clinical world, some of our diagnoses have actually, a couple of them have changed a little bit. There's actually one called disruptive dysregulation disorder now. That's in the DSM-5. But again, the DSM-5 came out way after this training was created. So some of the other things, if you've got kids who fall on the drug and alcohol exposure, the fetal alcohol spectrum disorders, there's a training that we just launched with the Adoption Exchange on fetal alcohol spectrum disorders. We do it by webinar too. And then if you have children, who've been exposed to certain drugs, in utero, the chemical or the substance that does the most damage to a developing baby is alcohol, more than any of the drugs combined. There's a little quote on here that just talks about adopted children are 3 to 6 times more likely to have mental health issues than the general population. With that, what's also happened is that our children in the foster care system are significantly on more psychotropic medications than the general population. That is now being addressed by the federal government. California was really the first state who has really been investigated on the significant amount of psychotropic medications that foster children are being prescribed in that state. And so that has launched kind of a watchdog effect on looking at every state and the foster care system, and looking at the amount of medications that very young children and even all of our children are being prescribed, and really trying to do some overhaul kind of on that system. So just something to pay attention to. Somebody's asking about oppositional defiance. It's not just fighting. If you shoot me an email, I can send you the specific criteria for oppositional defiance, or if you want to look, you can just go online and type in oppositional defiant disorder as it relates to the DSM, and it'll give you the exact criteria. It's pretty specific, but it's a little bit more involved than just fighting. And then if oppositional behavior continues as it relates to a mental health diagnosis, it usually kind of moves into what's called a conduct disorder when the kids get older. So look it up or shoot me an email, and then I can send it to you. All right, so some assessment areas. If you are in a position that you are working with adoptive families, and I'm going to apologize up front, this next couple slides might go little bit fast, but for the sake of time, I just want to be mindful of it. If we need to continue for the first part of next week, then we might go ahead and do that. But if you are in a position where you do assessments with adoptive families, so again, where a family is interested in adopting, or maybe even if they're coming into the system for the first time, maybe parts of this is already included in your home study or your adoptive summary. But these are things to really pay attention to. What is the current parental stress level? How do they manage their stress? What does that look like? Very concrete, specific examples. What's the parent's motivation for adoption? And are there any differences if it's a two-parent household? Are there differences in the motivation? That's something that we need to pay attention to. If you get the sense that one parent is really driving it and the other one is just kind of going along for the ride, doesn't really care one way or the other, that's a red flag. That's something that we have to pay attention to. What are parental expectations? Expectations as it relates to behaviors, as it relates to incorporating this child into their extended family. Do they think it's just going to be easy? How do they expect this child to be, to behave? What is their own history? Are there any pieces in there that we need to pay attention to that might impact their ability to be flexible and to be able to effectively meet the needs of these kids? What's their transition or their process into adoptive parenthood look like? What types of preparation have they had? What types of support systems? Do they feel supported? What else do they feel like they need? What are their attitudes and experiences with birth parents? This one is critical, just critical. What do they think about biological parents in general, not just the parents of the child that they may adopt, but birth parents in general? Are they going to be able to support the relationship that that child had with their birth parent? They need to work on their own anger and animosity towards birth parents, because if they don't, it's going to affect their relationship with this child. It will. It absolutely will. What about the adoption story and the child's curiosity about his or her origins? Are they comfortable doing a life book? Are they comfortable sharing pictures? Are they comfortable answering questions when the child asks them things about their birth family or their family before they came to live with the adoptive parents? What's the family's social support for adoption? This handout, again, just kind of gives you some assessment issues to kind of look at. This is, again, David Brzezinski. When interviewing adoptive parents prior to the child's placement, again, just kind of summarizes what was in that previous slide. So some assessment areas when you're working with the children. What's their early history? What's their trauma history? Their current functioning and symptoms. What are some of their current behaviors that they're working through? Any previous testing, diagnoses, treatment, assessments, recommendations, history of multiple caregivers. What's the child's working model? What are their survival behaviors? What's the child's knowledge and feeling about adoption and themselves? And their feeling about their birth family? Have we processed some of that grief and loss, that ongoing grief and loss? The communication about the adoption, what has that been like? What is the child's understanding of adoption in general? What do they think when somebody says, do you want to be adopted? And you have to stop and think, when we as adults use the word adoption, we think of something very happy and, we celebrate and, it's what we want to see. But when our kids and our adolescents hear the word adoption, they often think of very different things. Loss, have to change my name, I'm never going to see my family again, I have to love one or the other. Not super appealing for a lot of our kids and our adolescents. So we need to really break it down and ask them, what does this mean to you? Use other words besides adoption. What does it mean for you to live with this family until you're older? What does that mean for you? And what's the feedback from others about adoption? All right, so we already did that. All right, there's just one more slide, two more slides, and then we're done. So some treatment guidelines. Let me look and see. Just checking where we're at. All right, so adoptive parents, our recommendation is that adoptive parents must be included in therapeutic interventions. If it's a family system issue, family dynamic issue, we believe that adoptive parents need to be involved in some capacity. This isn't just they bring their kids, drop them off, and then pick them up, and they have no idea what's being worked on. They have no idea about the treatment goals. You know, they're not being asked their input. That's not effective when we're working with family systems issues. Safety and security are of utmost importance to successful grief and attachment work. Adoptive parents' feelings and experiences must be validated. Eliminate blaming for adoptive family issues. So really, again, try to uncover what's going on. Avoiding that imported pathology as a manifestation of the adoptive family's dysfunction. It is a normal occurrence that happens when children come into an adoptive home and try to stir it up a little bit, try to make it look like their previous chaotic environment. If at all possible, try to avoid therapist changes, be flexible in the number and length of sessions, maybe even the location of sessions. If you are a clinician and have the ability to come into the home, that's really powerful for a lot of our families, and that's where a lot of the behaviors and the interactions happen, where you can get involved right then and there. All right, sorry about the last few minutes. That was a little bit fast, but I'm going to turn it over to Shelly and Tara. I think they want to talk to you briefly just about the Adopt Care Advanced. And I want to thank you guys, and I'll talk to you next Friday.
Thank you, Denise. Yes, so we just want to kind of put in a quick plug for our next Adopt Care training. It's the Adopt Care Advanced. And we would like to open it up to everybody that's completed this training first before we open it up to caseworkers and professionals across the state. So you'll receive an email this upcoming Monday, and you'll have an opportunity to register for the training between Monday and Wednesday only, just for the participants in this training. And then we're going to close it starting Wednesday, maybe around midnight, something like that. And then it won't be open again until I believe March 5th or 8th, somewhere in there. So that everybody here will have an opportunity to get a spot before we open it up. And just to remind everybody that this training actually filled up really quickly within a week when we announced it. So if you really want to attend the Adopt Care Advanced, be looking for that email Monday, and I would say register it as soon as you can before Wednesday. And then Shelly and I just wanted to let everybody know that she and I are also adopted parents, and we're your area's resource coordinators, so feel free to refer people to us. And you have my contact information, and in the email that is sent out on Monday, Shelly's contact information will be in there too. And she covers the Denver, Colorado Springs metro region area, and I cover the southern half of Colorado. And the northern half of Colorado, if you live in that area, you can refer people to either her or myself at this time. Did you want to add anything, Shelly?
Nope, that's great. Look forward to having you guys next Friday.
All right, thanks so much, everybody. Have a great day.
Thank you.